Hello, everybody. Welcome, welcome, welcome. Tonight, I have something extra special for you. Our good friend, a physician, healer, and researcher, Dr. Sylvia Rosas is with us tonight. Dr. Rosas is a nephrologist and has been for over 21 years, and an epidemiologist at Joslyn's Diabetes Center in Boston, Massachusetts. She is a director of the Latino Kidney Clinic and an associate professor of medicine at Harvard Medical School. She is also a nephrologist at Beth Israel Deaconess Medical Center. She is the incoming president of the National Kidney Foundation. Dr. Rosas has special interest in diabetic neuropathy, cardiovascular disease, chronic kidney disease, minority health, epidemiology, and clinical trials. She grew up in Puerto Rico and as a teenager moved to Bogota, Colombia, where she graduated from the University of Rosario School of Medicine. Dr. Rosas then completed her internal medicine training at Michael Reese Hospital, the University of Illinois in Chicago. She obtained clinical nephrology training and a master's in clinical epidemiology from the University of Pennsylvania. She also completed the Wharton Management Program. She is board certified in the fields of internal medicine and nephrology. She is also a fellow, so we've got a very smart doctor with us tonight. Dr. Rosa's primary research focus is on the epidemiology of metabolic and cardiovascular disease complication in patients with chronic kidney disease, and in particular with diabetic kidney disease. She has also evaluated health disparities in individuals with CKD, particularly those with a Hispanic Latino background. She is the clinical center leader of the NIDDK-funded multi-center Apoll1 long-term kidney transplantation outcomes network, or Apollo, that evaluates the role of the Apoll1 gene in kidney transplant outcomes. She is the top doc for the Kidney Precision Medical Program, chronic kidney disease recruitment site at the Joslyn Diabetes Center. The KPMP aims to ethically obtain and evaluate kidney biopsies in order to create a kidney tissue atlas, define disease subgroups, and identify critical cells, pathways, and targets for novel therapies. She served as chair of the Minority Affairs Committee of the Organ Procurement and Transplant Network, United Network for Organ Sharing, or UNOS. She has been the secretary for Women in Nephrology, as well as the program chair for NIDDK Network for Minority Health Research Investigators. She has received numerous awards, including the National Kidney Foundation of New England Physician of the Year in 2017 and the National Hispanic Medical Association Fellow of the Year Award. She has been a long-time volunteer with the NKF and has been a member of the Spring Clinical Meeting Planning Committee, a judge at the Young Investigators Forum, and a member of the Scientific Advisory Board at the National Kidney Foundation. On a local level, she has been a member of the medical board for the NKF New England chapter. She has served as a member of the editorial board for the Clinical Journal of American Society of Nephrology and the Advances of Chronic Kidney Disease Journal. Last, but far from least, as I said, she is the new incoming president of the National Kidney Foundation. Straight away, she has set out her goals for the administration. Quote, "During my term as president, I would like to continue to focus on public awareness of kidney disease, particularly diabetic kidney disease, the most important cause of kidney disease worldwide. I have been an advocate for eliminating barriers to kidney donation as well as reducing organ discards. In addition, there are significant disparities in both who is at risk for developing kidney disease and how treatment is applied. I plan to continue advancing these areas. I have been dedicated in my entire career to support programs that address and find solutions for these health disparities. In addition, I will continue to work to increase gender and racial diversity in the healthcare field." Please give a warm welcome to Dr. Sylvia Rosas. Doctor, how are you this evening?
I'm fine. Thank you very much for inviting me to your program, and I want to welcome our listeners.
Okay. Did I state everything correctly in the introduction?
Yes. Thank you very much.
Please tell us a little bit about where you grew up, your educational experience, and a little bit about your employment background.
Sure. So, as you mentioned, I grew up in Puerto Rico. I actually was not born there, but when I was one or less than one, my family moved there, and both of my parents were working. And when I was about 13 or so, my father's from Colombia, so he decided that he was going back to Colombia, and that's why he moved the whole family there. So I finished high school in Bogota, Colombia, and I did medical school there because that's where I was. But when I finished medical school, I knew that I wanted to obtain my postgraduate work, my nephrology, internal medicine and nephrology training back in the United States. And so I moved back initially, as you mentioned, to Chicago and then to Philadelphia. And then after I finished training and I was in faculty at the University of Pennsylvania for about 13, almost 14 years, then I moved to Boston to my current job.
Okay. Let's talk about some of your special interests in your profession. Please explain how you developed an interest in chronic kidney disease, kidneys and diabetic kidney disease, for example.
So diabetes is the number one cause of kidney disease in the world, and it's particularly important for the Hispanic population. Actually, one in every two children born in the United States today of Hispanic background will develop diabetes during their lifetime. So it's very, very common. Part of it is the increased incidence of obesity, but that leads, obviously, if you have more diabetes, that also leads to more chronic kidney disease due to diabetes. And so there's also a big disparities in treatment, what type of medications people receive, what type of access they have to care. There's sometimes language barriers, not always, but sometimes. And so that's why I think it's very important to I'm bilingual, so I focus on the Hispanic population. I see everybody, but I have a clinic that is specially dedicated to Hispanic patients.
Okay. Talk to us a little bit about your interest in cardiovascular disease and minority health.
You know, things evolved. When I first came to the States back, when I told you I was starting training, I worked for a cardiologist. And I think that's where my interest in cardiovascular disease. I worked in his office. I was helping him with his cardiovascular patients. And cardiovascular disease is the number one cause of mortality in our patients, particularly heart failure. So as kidney disease progresses, our patients are more likely to develop cardiovascular disease. So it is quite an important comorbidity and a very important risk factor for mortality too. So that's why I was interested in cardiovascular disease. Initially, I did some work on vascular calcification, looking at why our patients are at increased risk. I don't know if your listeners know that as kidney disease progresses, patients with kidney disease are more likely to have calcification in their blood vessels. And so this can lead to problems and it's associated with increased mortality, those that have calcifications and those that their calcification progress. So those are very important topics, and I've done some work in that area.
Excellent. Talk to us a little bit about your interest in epidemiology and clinical trials.
So I think that's very important. I think that participating in clinical trials for everybody, but also very important for the underserved communities, for women, people that are not always represented in clinical trials, that it's important to participate, because otherwise we don't know if the medications that are currently being approved work for everybody. right? And so I think that's very important. And I think that when patients come to us, sure, we all provide the standard of care, but frequently, sometimes it doesn't work, or people want to know what else is there out there. And so I think that it's important to work in a place like where I work, where we're also looking at what is in the pipeline, what is coming, is it going to work or not? So, for example, I participated in the new trials that have two new medications that are very helpful for the treatment of diabetic kidney disease. So we participated in those trials, and even though not everybody was on the study drug, some patients got the study drug 3 years before it was approved. So they got the benefit, half of the people that were in the study got the benefit of being on the study drug that now has been approved. So that I think that it provides a benefit to the patient, obviously, if the drug works. But I also feel that if the drug doesn't work, it is also very important because patients get seen more often, even though it's not clinical care, and they learn more about their disease. You learn a little bit more about self-management, etc. So I do feel, and again, it depends on the burden, and some people, there are research studies that are just surveys versus the research studies that you're the first one to take a medication that nobody else has taken. So there are degrees, and so as far as research is voluntary, so you have to see what your degree of risk taking is. Some people like to jump out of a perfectly good airplane, and others, I've never done that. So I'm a little bit in the middle. So if it's a medication that has already been tested and this is the last trial before it goes to the FDA, I like to do those type of trials.
Okay. You submitted some questions to me tonight. Now, let's go over a few of those. A lot of patients have kidney disease and don't know it. Can you address why is it that they don't know?
Yeah, so that's a very important question. I don't know if people know that 9 out of 10 patients have kidney disease and do not know it. And about 4 out of 10 people that start dialysis, we actually start dialysis when they show up to the emergency room. And that's when they learn that they have kidney failure. It's like a total surprise. And the reason that is because there's currently no guideline to screen patients for chronic kidney disease. And so the National Kidney Foundation is trying to work with the U.S. Preventive Service Task Force to issue a recommendation that prioritizes screening and early detection for people that are at high risk for chronic kidney disease. So those are the people, as we discussed, those with diabetes, but also people with hypertension, or people with a family history of kidney disease, or people perhaps with cardiovascular disease. Again, the task force has to decide whether they look at the evidence and they will issue their recommendation. But we are supportive of the review, and so we're very happy that they are taking that on this year. About a decade ago, that was the last time they evaluated it. And this would be really critical because it raises awareness of kidney disease. Those guidelines are reviewed by primary care providers. And so it's very important that everybody, the whole health system is helping us screen for kidney disease. And, also, as I mentioned, now we have 2 newer medications, or 2 types of medications that are through rigorous clinical trials have shown that they offer both kidney benefits and heart benefit protections for patients with kidney disease, whether it's diabetes or not diabetes. And we need to work with our health systems, our payers, to make sure that these medications are covered by their insurance and are available at a reasonable price to everybody that is at risk. We want to be preserving kidney function as long as we can in the best possible way. So these are very exciting times for kidney disease.
Okay. Which medications are these, doctor, that you're speaking of?
So the classes of medication, one class is called the SGLT2 inhibitors, And those are, I'm not sure if I'm allowed to do the generics or the brand names. Those are all the medications that finish in Flozin. And then the other type of medications are called non-steroidal mineralocorticoid receptor agonists. And those have been derived from a medication that was in the market for a long time called spironolactone, and the new medication is called finerenone. So the SGLT2 inhibitors are the ones that are canagliflozin, dapagliflozin, and empagliflozin. And the first two have an indication for kidney disease. So they've been FDA approved through rigorous clinical trials that they are helpful for patients with kidney disease.
Okay. You have mentioned in your notes some work that's being done by a preventative service task force. Can you tell us a little bit about that, please?
Yes, that's what I had mentioned, that about a decade ago, the task force has reviewed whether there was evidence that it was helpful to screen patients for kidney disease. At that time, they said they didn't think there was enough evidence. And right now, they have reviewed the NKF submitted a letter or request to ask them to review it again. And we are fortunate again that the U.S. Preventive Task Force has said that they will review the screening. We feel that there is some increasing evidence that screening and early detection may be helpful for, again, these individuals at high risk for chronic kidney disease. And now we have the therapies to treat it. So there is definitely a benefit for treatment. So we're hopeful. Again, I don't know if they will approve the recommendation, but hopefully they will review it in the coming years and we will have a recommendation for screening.
Okay. There's a new equation to estimate kidney function. Why was the change made?
So in recent years, there was advocacy from our medical students and from our diverse faculty that I don't know if patients are aware, but the way we estimated the kidney equation had three variables: age, gender, and race. And race, as we know, is a social construct. It's very hard to look at somebody and say what percentage of what race they are. And so it felt that it was inappropriate to use race in the equation. And therefore, the National Kidney Foundation and the American Society of Nephrology worked together to create the NKF ASN task force on reassessing the inclusion of race in diagnosing kidney disease. And they issued a unified approach in September 2021 to use a new equation. And this new equation uses creatinine, age, and gender only, and there's no race available. As you know, race is used in many medical algorithms, and we are quite proud of the fact that nephrology was the first specialty to eliminate race from a clinical algorithm. And so currently we're working, there's an app in the NKF website, and we're working with major laboratories to use this new equation rather than the old equation that gave us different numbers for depending on what race you were. And so many of the hospitals around the country are already implementing these changes. So if you go to your doctor, please make sure that they're using the new 2021, we're calling it the CKD EPI refit equation, so that they're using the latest formula. We also didn't want, we want to make sure that everywhere in the country uses the same equation. Otherwise, it would be very difficult that, you go to one place, they tell you have this level, and in another place, they tell you they have this other level. So we want to make sure that as a community, we use the latest formula.
Okay. How is the NKF working to eliminate health disparities?
So the NKF has worked throughout their life in eliminating disparities, and it's committed to continue to work towards this. for those that you may not know, minority patients are more likely to end up on dialysis or require transplant, but are less likely to be seen early by a kidney doctor. They're less likely to be referred for transplant evaluation, and they're less likely to have a living donor. And the NKF has formed a health equity advisory board that's in charge of directing and championing the NKF's health equity, the community health, and social justice efforts through research, education, and partnerships. We've looked at all of our websites and education material and made sure that it had the right spirit and the right words were being used. And we have also issued a request for application for research studies that seek health equity related to kidney health at a community level. So we want projects that will have an impact in preventing, reducing, or eliminating kidney health disparities and advancing health equity in local communities at risk. Because what we want is, if it's working locally, maybe with the help of the NKF, these programs can become national programs that will help us eliminate health disparities. So we have received this call for applications ended, I think mid-February. So we received an outstanding number of applications. We're working on reviewing them, and we're meeting in the upcoming weeks to decide which projects to fund, which they will start this next July.
Okay. You also requested that we discuss the impact of COVID-19 on people with kidney disease. Can you address that, please, a little bit?
Yeah, so as we know, COVID-19 has impacted everybody around the globe. Unfortunately, kidney patients were vulnerable to the virus, particularly our dialysis and our transplant patients. And it's with great sadness that in the last 50 years that, that Medicare end-stage renal disease program has started, this is the first time that we have less dialysis patients than we've ever had. And that is not because we're curing kidney disease, but because they unfortunately succumb to COVID-19. Our patients, unfortunately, were not prioritized for vaccination or to receive the prophylactic long-acting antibody. So we're working hard to make sure that our hospitals that struggle to provide sometimes dialysis because they didn't have either the supplies or the staff, that we're able to work to eliminate these issues. And I want to remind our listeners that if you should get educated about the vaccine, and we still highly recommend, particularly for dialysis and transplant patients, to get vaccinated. I know that we all feel that, 2.5 years is enough with this pandemic, and some of the restrictions have been lifted. But if you're a transplant and a dialysis patient, you're still at risk, and you should take precautions.
Okay. Talk to us a little bit about your experiences with the Apoll1 Long-Term Kidney Transplant Outcomes Network. Why was that work important?
So the Apoll1 gene is a gene that evolutionary helped people that had that gene. They didn't get a disease in Africa that's called sleeping sickness. But in recent studies, it was found that people that have two risk alleles, so you had to inherit one from your mom and one from your dad. So if you had two of the risk alleles for Apoll1, then you're more likely to get kidney disease. But it turns out that 10 to 13% of African Americans in the US have two risk alleles, but not all of them develop kidney disease. So it's very important to understand who develops kidney disease and why that is. And so in this particular study, we're looking at transplantation. We're trying to see if the donors, so these are deceased donors or living donors of African American descent, if the kidney has two risk alleles, are those kidneys lasting just as long as all the kidneys, or is it the survival less? And more importantly, we're very interested in finding out what happens to the living donors. We don't want to, we want to make sure that we don't have patients that have 2 risk alleles, and we ask, we take one kidney and then they're at increased risk for developing kidney disease themselves. So that's why the study has those 2 interests, trying to see in the deceased donors if the survival is the same or if they're more likely to get certain events like rejection or more proteinuria, etc. And then making sure that our live donors that are altruistically giving their kidney, that we're not putting them at increased risk.
Okay. Talk to us a little bit about your work with the Kidney Precision Medicine Program, the Chronic Disease Recruitment Group at the Joslin Diabetes Center.
So the KPMP, we call it for short, it's Kidney Precision Medicine Program. It's also sponsored, the Apollo study, the one I discussed before, sponsored by NIDDK, which is the institute in the that covers digestive diseases, diabetes, and kidney disease in the National Institutes of Health. The KPMP is also sponsored or funded by the NIDDK, and it's looking to obtain again, these are altruistic kidney biopsies in order to create a kidney tissue atlas. And what does that mean? So nowadays, we only biopsy people that are at the extremes. So for example, if I see a patient and they have proteinuria, they're losing kidney function slowly over time, their proteinuria is relatively low, we don't biopsy them. Right? We just say, oh, you've had diabetes for 25 years. This is probably diabetes. And in reality, we don't really know that they have diabetic kidney disease. We just say, oh, this is most likely diabetic kidney disease. And so now we're asking our patients, look, you have proteinuria. Are you willing to do a kidney biopsy so that we can better understand the pathways? Because we know that people with the same kidney function and this same proteinuria, if you look at them under the microscope, one may have more scarring of the tissue or more of the filters damaged than the other one. And we don't really understand why that is. Or one may have more inflammation, etc. So it's kind of like we're trying to do what cancer has done so many years ago. Now, when you develop a cancer, they tell you, oh, you have this receptor. So because you have this receptor, I'm giving you this medicine. Or you have this hormone that's elevated. So because you have this hormone elevated, I'm giving you this. In kidney disease, we don't have that. We treat complications. We treat blood pressure, we treat swelling, we treat etc. But we're not giving somebody a medication to, let's say, grow more filters or get rid of the scarring or something like that. We need to understand the progression of kidney disease. What is normal progression? And what pathways get activated? Is it inflammation? Is it scarring? What pathway is done? What cells are involved? Because then we can create a medication to say, oh, look, this cell is involved in the inflammation. Let me see if I can give some medicine that goes straight there and try to kill those cells that are really going to hurt the kidneys. So that's the type of thing that is being done. We're very fortunate that the patients at the Joslin and the Beth Israel are interested in research. And so far, we've had about 23 altruistic donors. And again, these sites are across the country. There's a site in Cleveland. There's a site in Dallas, Texas. There's a site in New York, in Pittsburgh, and I'm missing one. It'll come to me. So we're all working together to find to create this tissue atlas so that we can find these new pathways and targets so that we can find new medications to treat chronic kidney disease.
Okay. You acted as chair of the Minority Affairs Committee of the Organ Procurement and Transplant Network for UNOS. Can you explain what the importance is of that particular work?
Yeah. So UNOS is the is our national organ procurement and transplant network, and they have different committees. So they have a committee for, let's say, lung and liver and kidney, etc. And they have one committee that's called the Minority Affairs Committee, because sometimes when we create one policy, or we try to make one policy, that policy may affect people differently. And the Minority Affairs Committee, their job or their mission is to make sure that any policy that is implemented is equitable, so it doesn't impact rural areas more than urban areas, doesn't disproportionately affect the elderly, for example, or people that don't have education, or people of underrepresented minorities. So that's the work of the Minority Affairs Committee. So when policy is enacted or new proposals are seen, we review those and comment on those. Or if we see something that might be helpful, we sort of champion it to make sure that it moves forward.
Okay. Tell us a little bit about the group Women in Nephrology. Why is their work important or significant?
So Women in Nephrology is a great organization. You may not know this, but about maybe 20% of kidney doctors are women, depends on what area you're in. So it's very important to have an organization that that helps not only the academic, but also leadership support. So Women in Nephrology every year has a leadership seminar, and it also provides a review of CVs. It serves as a real sponsor for Women in Nephrology. And I have to say that I feel that my contributions to organizations like the ones that we're discussing, and for example, Women in Nephrology, really provided me the experience to become to sort of hone on those leadership skills that later became important for other activities. And also, we all, as women, again, everybody has a different life, but we have constraints and lives that are different, or issues that are different to men. And so, I think that to have that organization, it was quite helpful. And I also want to say that the mentorship program that Women in Nephrology does is for both men and women. So I just want to highlight that for that that leadership seminar, both men and women are invited. And women and men can join Women in Nephrology. And in fact, we have some excellent male sponsors that are very active in the organization. But things that Women in Nephrology, they would look at, if there's an award that's being provided by a major organization, we are supportive, writing letters to make sure that women have the same chances of being, this very deserving women get into leadership positions and have the support of the organization. And if they're giving a talk, etc., sometimes we're approached by different organizations because they are looking for a woman, for example, somebody that works on polycystic kidney disease. They have a conference. They want to make sure that they don't have a manel. And for those that don't know, a manel is a panel that only involves men. So they contact us to make sure that they are, again, provide equity in who their speakers are.
Excellent. Talk to us a little bit about the Network for Minority Health Research. What's going on there?
So this is an organization that is also sponsored by the NIDDK and many organizations like the American Diabetes Association, the American Society of Nephrology, the Liver Society. They sponsor some of their members to join for usually a 2-day meeting. It's usually done in DC, and senior faculty that have experience in minority health research supports more junior faculty or sometimes fellows in so that they can develop their research careers. So we, when I was younger, they reviewed my abstracts or my specific aims for my grants or things like that, and now I do the same. So to help people, what their CV should look like, where should they go for interviews, help them with certain career decisions, and more importantly, review what their aims are, where they should apply for grant application, more of a faculty development, leadership development, all with a focus on minority health.
Okay. Let's talk a little bit about the awards that you have received in the past. I have you as the NKF New England Physician of the Year in 2017 and the National Hispanic Medical Association Fellow of the Year Award. Can you tell us a little bit about what all went into that?
So, I hadn't mentioned the National Hispanic Medical Association. So many years ago, I want to say maybe 20, but it could be when, I don't remember now, but probably like 20 years ago, I did like a fellowship, and they were instrumental in, it was a public advocacy fellowship. I think they call it the Leadership Fellowship, but it was basically to learn how to advocate for Hispanic patients. And so teaching us what is important, where the bills are done, who, how government works, etc. So I think that was in the beginning of learning how we can learn how to be a better advocate for our patients, how to get involved in public policy, how to be supportive of bills, how to champion, not only what we want, but other people's ideas, and so that we can move the field forward. So I hadn't discussed the National Hispanic Medical Association. I am still involved, but anyway. So they have a Physician of the Year award, and they recognize some my work with kidney disease, and that was what that award was. And the National Kidney Foundation of New England also recognized my work in the Hispanic community in New England with the establishment of the Latino Kidney Clinic at the Joslin. This year, actually, I got the American Society of Nephrology Distinguished Leadership Award from, again, the American Society of Nephrology, which it was a tremendous honor. And just recognizing all the work that has been done that you're highlighting now.
Okay. You've had some long-standing appointments and experiences with the National Kidney Foundation, a member of the Spring Clinical Meeting Planning Committee, a judge at the Young Investigator Forum, a member of the Scientific Advisory Board, a board member with the NKF New England chapter. Can you talk to us a little bit about your experiences with the National Kidney Foundation?
Sure. So the National Kidney Foundation, as all of the patients know, is a wonderful organization. It's patient-focused, very interested in patient education. I mean, I've been really honored, and I've learned a lot from the, when you judge one of these scientific meetings where the young, bright next leaders in the field come and tell you what they're working on. It really energizes you and tells you, okay, this is great. You learn a lot, and it, I also feel that we have to support the field and make sure that the field moves forward. I'm no longer in the young part of it. I'm probably like in the second half of my career. So it does feel great to work with a younger younger faculty, and make sure that their careers take off. And we like to do that. And for example, when we work in the program committee, we want to make sure that we have a balance, that we have some senior faculty, but we also have some middle, let's say mid-career faculty, and that we also invite some younger faculty so that their careers can also take off.
Okay. Let's talk about your work as a professor of medicine at the Harvard Medical School. What were your experiences there?
So Harvard, as you know, is a big place, and you have to find you need to find sort of your place and what you really enjoy doing. Like I said, I was very interested in moving because the faculty and the resources that were available, it was really spectacular. I enjoy working with our fellows who are in training and participating in clinic and in patient care. And that's basically what I do there. So.
Okay. Talk to us about being a member of the editorial board of the Clinical Journal for the American Society of Nephrology and Advances for Chronic Kidney Disease Journal.
Sure. So the Advances of Chronic Kidney Disease Journal is a journal of the National Kidney Foundation, and it provides reviews up to date of whatever topic. So, for example, recently I guest edited together with Dr. David Cherney from University of Toronto the issue that was from diabetic kidney disease. So the whole journal was dedicated to these medicines that we discussed earlier, the newer medicines that are associated with good outcomes, how diabetic kidney disease, what we think of it now, etc. So it provides a nice summary, the whole issue on the same topic, and it's up to date. So that's great. But there are other topics that have been of great importance. Obviously, there was a topic that was COVID. There's been a topic on workforce issues in kidney, in nephrology, not just faculty, but also staff and nurses, etc. There were other issues have been like, how does kidney disease impact pregnancy, things like that. So those are sort of the role. We get the articles, we review it, we decide what gets printed or sort of on the images, and how to make it so that the readers enjoy it in a manner that they can not only learn from it, get a very good and accurate, up-to-date information on what's going on there.
Okay. Let's talk for a minute about your goals as the incoming president of the National Kidney Foundation. First of all, when does it take effect that you're actually the president?
In October, after the board meeting in October.
Okay. Let's talk for a minute about the Advancing American Kidney Health Initiative. Can you talk to us a little bit about what's going on with that?
So in the Advancing Kidney Care Initiative, there are some programs to increase home dialysis. There is an interest in increasing donation, in eliminating discards, all of which the National Kidney Foundation has supported and has worked for many years, even before the National Kidney Act. I think that it was important because I think at least it gave some visibility to kidney disease, even though it didn't really come with any money, which usually always helps when things come with money, right? And as you have to remember that now that we talk about money, it's very important that, there's 800,000 people on dialysis, more or less. Dialysis costs more or less 90 to 100,000 each year. And so Medicare spends about $130 billion in this fee-for-care system that we have. And unfortunately, we're not spending the appropriate amount of money that we need for research. So we spend all this money in treatment of kidney failure, but the research, the NIDDK, which is the organization that, again, I discussed previously, is the one that gets the money that people apply for to study diabetes, digestive diseases, and kidney disease. That's where the K for NIDDK goes. They're spending right now, the NIH, only $18 per patient that has CKD in research. But we're spending all this other money treating kidney disease. And for patients that are HIV positive, they're spending over $2,000. For patients that have cancer, they're spending over $500. So obviously, that explains a big difference why there have been so many advances and new medications in those fields that we are not seeing yet in kidney disease. So we are hoping that you join the NKF, you and your listeners, to try to advocate for that the NIDDK gets the appropriate amount of funding that is required so that we can find these novel therapies.
Okay. Let's talk about a little bit about disparity in healthcare and eliminating barriers to kidney donation. It's my understanding that Afro-Americans and Hispanic Americans tend to get kidney disease earlier than white people. It's also my understanding that those same two groups are not referred as frequently to experts, to nephrologists, to someone that can help them, or they're not as referred as quickly. It's also my understanding that in terms of transplant, they have more difficulty getting listed, if they get listed at all, that they tend to wait longer than the rest of us, that they have more difficulties obtaining a kidney transplant and getting good treatment after kidney transplant. Can you talk about this idea of eliminating barriers to kidney donation and to discrimination based on race and ethnicity?
Sure. So there are so many things here that I think I'm probably just going to scratch the surface. So Hispanics and African Americans are more likely to develop kidney disease and end up in kidney failure. And I discussed one of the things that we believe may have an impact, which was Apoll1 in patients that are of recent African ancestry. However, there is a significant, even after adjusting for Apoll1, we do believe that social determinants of health play a big impact on who develops kidney disease and treatment, etc. Because if you live in a place where you cannot exercise, where you cannot buy the appropriate foods, then obviously your diabetes is going to be out of control. Your blood pressure, if you don't, if all you find is fast food and carbs, again, blood pressure, diabetes is out of control. And then if you work every day, and if you skip work and you're not going to get paid, we all know how long the transplant evaluation takes and how many days you have to miss from work. And so if you are afraid that you're going to lose your job, it takes longer. So there are many barriers. Transportation is a barrier, etc. So that's why we're trying to find ways to do this in that way that is sensitive to everybody. So for example, one solution that has been brought is a patient navigator that may help the patients navigate sort of their transplant work, so that they can say, okay, we'll book your appointment, or we'll help you with the language, we'll help you with the Uber, whatever it is that needs to be done, so that it needs to, so that the patient can navigate the system. Because I work in the system, I can tell you sometimes it's not that easy. So we want to do that. So it takes really a village to eliminate disparities, because it's not something that the NKF can do alone. We need the health systems, the government, the funders, the payers, the patients, everybody to really come up with solutions for this problem. But we're eager to tackle it, and I think that we can do it.
Okay. You sent me questions, and you've mentioned during the broadcast raising of public awareness of kidney disease, and in particular diabetic kidney disease. Can you speak to that a little bit?
Sure. So as I mentioned before, diabetic kidney disease is the most common cause of kidney disease in the United States. There are 37 million Americans that have chronic kidney disease, and we believe that about half of them is because of diabetes. And patients with diabetes, the issue with chronic kidney disease is that, it's not like pneumonia, that people get a fever and get short of breath, so you go to see your doctor immediately. Chronic kidney disease, to be able to be diagnosed, you have to have a blood test and you have to have a urine test. And only with those two, you can test in the urine whether you have albumin in the urine, and in the blood what your creatinine is, and then use that formula that I talked about before, the CKD epi refit equation, and plug it in, and it's in the NKF website, the new formula. And then it tells you what your GFR is, which is how much blood you filter every minute. And then you have to know your number, the same way that you know your A1C, the same way that you should know your cholesterol, you should know your GFR. If you have diabetes, if you have hypertension, if you have a family history of kidney disease, you have to know your numbers. And because at the end of the day, you are the person that cares most about your health, and you do it for yourself and for your family. And therefore, these numbers are vital. So once you know your numbers, you just track it over time, you and your primary care provider. There's only about 12,000 nephrologists in the United States. So that's why I say so much that we need to work with our other providers, because our primary care providers, there's millions of them, and they need to help us screen. We don't need to see everybody to tell them, no, you don't have kidney disease. But the primary care provider can screen the patients and obviously refer those that need to be seen to slow progression of kidney disease to their kidney doctors. So I think in the past there has been certain inertia, let's say, or some certain thing like, oh, you have kidney disease, there's nothing to be done. But that is not true anymore. And I think that there are treatments out there. And therefore, if you have kidney disease, please see your kidney doctor.
Okay. One of the big themes that I see in articles about you over and over and over again is your desire to reduce organ discards. Can you talk to us a little bit about the importance of that?
Sure. People may not know this, but about more than 20% of all organs procured in the United States are discarded, meaning that they're not transplanted. And when we have so many people waiting for a transplant, it's really, I find it unacceptable that the discard rate is so high. And therefore, we need to understand what is happening. Why are these? Some obviously are discarded because they're no good. So those obviously we don't want to transplant. But there are certain ones that, why is it that they're being discarded? And I want to say that there is an initiative from the National Kidney Foundation to try to understand why this is and try to make sure that the discard is eliminated.
Okay. One of the things that you mentioned to us tonight is the desire to increase gender and racial diversity in the healthcare field, that more doctors that are Afro-American, more doctors that are Hispanic, Latino, more healthcare providers in general that are minorities should be considered and included. Can you speak to us a little bit about that issue, please?
Oh, yeah. So unfortunately, there are many barriers to, one has to start with high school, right? People that don't finish high school don't go to college. And then people that don't go to college don't go to med school. And people that don't go to med school cannot be faculty at our universities, right? So we have to start early on and make sure that that everybody is able to graduate, that everybody is able to go to college. Then that once we have people in college, don't discourage them from going into medical school. There's a lot of people that are interested in being doctors, but are being told, you don't have what it takes, it's going to cost so much money, you don't have the time for that. They have other pressures, like, they just finished college, so now they have some college debt that they don't want to get medical school debt, etc. So we are trying to work making sure that we encourage people to continue in the pipeline, that we help them through. We help them with their applications. And for example, the National Hispanic Medical Association has a program like that, where I mentor medical students to make sure that they continue in the track, because it's what they call a leaky pipe. Everywhere there are people, we miss opportunities to bring them along. And I think one of the most severely affected are African American males. They are the least represented. They're only like 1 or 2% of the whole faculty. I think it's 1%, because I know that female Hispanic women are 2%. So I know it was less than women. So it was 1% of African American faculty in the U.S. are African American males. So that is like, we really need to work there and make sure that they move through the pipeline, because we know that from patients that there's multiple studies showing that if your doctor, not only, they don't necessarily have to be from the same race, but they have to be, the patient has to feel that you're treating them culturally appropriate, that you're being respectful, that you're treating them, listening to them, etc. So once you have good communication skills, the outcomes are better. And it is true that if they have racial concordance, that's what they call, patients, they've shown that screening tests are done more often, blood pressure control is better, things like that. So so we should make sure that if, I think it's 15% of the population is African American, the dream would be that 15% of the doctors are African American. If the 18% of the population is Hispanic, the dream would be that 18% of the doctors would be Hispanic. That is the dream. But, you know, we're nowhere near there. I think it's 6% of the whole faculty is minorities. And
Okay.
the rest, yeah.
Doc, we're in the home stretch here.
Mhm.
Is there anything else that you would like to discuss or that you have to say before we conclude our conversation for the evening? Is there anything that I forgot about that's important to you?
Well, I just want to make sure that the listeners know that you know, they can go to the NKF website and become advocates for kidney disease. That there is hope for treatment. That we're working hard to bring education to them, and of course, we're always eager to learn what our patients want or would like for us to do. So please communicate with us. And I think that's it. Just trying to raise awareness of kidney disease. It's the most important. Thank you for inviting me to your program, and thank you for the listeners.
Well, we learned so much tonight, Dr. Rosas. Thank you so much for coming on and talking to us the way that you have, and we greatly appreciate you're taking time off of your busy schedule, and I know you're a very busy person. So thank you so much for coming on, and boy, lots of great comments tonight from the listeners. So we will talk soon. I'll see everybody next Friday.
Thank you.
Take care for now. Okay, Doc, I'm going to go ahead and end the broadcast. Thank you.
You're welcome. Bye.
Bye-bye now.